Good evening. Thank you. Yeah, that picture on the screen, that cartoon, shows that man, the pedestrian, hooked onto his cell phone. To him, that honking car is a nuisance, right? So the line that separates a nuisance from a real warning is depends on our perspective, right? So take pain. The patient sitting on the hospital bed, to him, pain is a nuisance. Oh my God, doctor, I have pain. In contrast, the doctor thinks, warning sign. It was Tuesday, June this year, 10:30 in the morning. We were doing our morning rounds in the intensive care unit. One of our junior consultants in rounds with us suddenly said that he felt some kind of funny chest pain. Chest pain. We quickly put him on the bed, got an ECG done, and that showed a developing heart attack. A surprise. So we quickly took him to the cath lab, did an angiogram that showed a developing block. The block was quickly removed and he was out of danger. Exactly a week later, next Tuesday morning, this young man was doing the same rounds with us in the same intensive care unit, making important patient care decisions. So see, the technology that we have today is fantastic. And heart attack, which had a death rate of about 20%, only about 10 years back, today is totally curable. But think about it, if this person, the patient cum doctor, had not complained of the chest pain, the dumb $1 million technology would have sat there doing nothing. So it's important that we get hold of a complaint, a pain. Sometimes we say that a silent heart attack is the best way to get out of this world. I fully agree. When my time comes, I prefer to have a silent heart attack, painless one, in my sleep, in my own bedroom, right? But if you want to live, if you want to get back to your work, bounce back to your work, a painful one is your best bet. Now the problem is here. Pain is a poor warning signal. Pain is a poor warning signal. What do you mean? We have about 6 trillion cells in our body, and just 6 of them are shown there on the screen. 6 of them. They're all good, normal cells. They're nice guys. They are very decent. They are disciplined. They don't even multiply unless there is a need to. Right? But once in a while, somewhere deep inside our body, without our knowledge, one of those normal cells transform into a cancer cell. We call it mutation. Now that cancer cell is a bad guy. That fellow doesn't obey anyone, he's indisciplined, he's violent, like a mob, quickly grows up into a large cancerous tumor. And at that point, cancer is extremely painful. And that is why cancer is a dreaded disease, right? Think about it. As a doctor, we are bothered about the painless transition of that first normal cell to a cancer cell. If we could make that painful, the patient would have come running to us at that first cancer cell stage and cancer could have been curable, right? So we pray, God, please make it painful, not at the last stage, but at the very, very early stage. And that's why we say that if we consider pain as a warning system, it's not a very good early warning system. Pause for a moment. That is the caricature of the statue of Hippocrates, the father of modern medicine. Now, many people don't know that it's Hippocrates who brought in the concept of humor in medicine. Humor in medicine, not this kind of humor, no. Humor in Latin means fluid, liquid, right? So Hippocrates said that the human body is full of colorful liquid. Yeah, it's true. For example, he said that prick him with a needle and red liquid comes out. Okay, he coughs out white phlegm. He vomits yellow bile. So red, white, yellow, colorful bag of fluid, right? And then he went on to say, of course, that all the diseases are caused by the loss of balance of this kind of liquids, which was nonsense. But what people, researchers on Hippocrates miss out, and what I feel is this, his most important contribution in medicine is a concept of black humor. Black humor. He said, black humor is a chemical that increases in the body when a person has chronic aches and pains, is depressed, he doesn't talk, is aloof, secluded in a room, melancholy. So you see, this man was talking about a chemical reason for development of depression. 2000 years back, when nobody had dissected the brain, there was no microscope, no one knew about neurons, nerve cells, nobody ever thought of those little chemicals that talk between nerve cells, neurotransmitters, and this man was talking of a chemical reason for depression. Fascinating. But what is interesting is that in 2014, Christmas, two young researchers, Philip John and Patrick Montgomery, they published a paper in British Medical Journal where they tested the simple questioning pattern of Hippocrates. They're simple questions. They asked like, how are you? Do you have good appetite? Do you have good cognition? How is your memory? Simple questions, and try to see, does it predict in a modern era the outcome of the patient? And they found, very interestingly, the survival probability of a 72-month-old period, that is 6 years, is clearly predicted by whether the question answer is yes or no. The graphs are separate. Understand? No scans, no blood checks, no high-tech angiograms. Simple questioning would still tell us how a patient is going to do in the long run. So it's important that we listen to the patient for some time, and that might give us good clinical information. Now, this is the concept. We go to a doctor, that used to be, we go to a doctor with a pain, or pain doesn't just mean pain, symptoms, complaints, and the doctor treats us for that problem and we are cured. That used to be what would happen 200 years back. But quickly we realized that pain is not enough. For example, a chest pain may be a muscle pain, innocuous, or a massive heart attack. A stomach pain may be an indigestion, or a big ulcer going to bleed tomorrow. So a symptom has very little value. So we migrated on to a concept of disease, and we started treating disease, right? Which is a good thing. It's a good thing. So we migrated from symptomatic treatment to a disease-based, disease-focused treatment. And to do that disease-focused diagnosis and treatment, we needed high-tech. So scans, blood checks, angiograms, endoscopes all came in. And that's a good thing because we got a good outcome. But what we will show you in the next 10 minutes or so is that even today, in this era of high-tech, that initial symptom of pain decides how it's going to be the long-term outcome of the patient in this era of high-tech medicine. And if we forget that, things might actually get into a problem. Take, for example, that is an echocardiogram, a scan of the heart, showing heart valves. Now, heart has got 4 valves that open and close thousands of times a day. But in some diseases, the heart valve gets damaged. And that shows the damaged aortic valve in the heart. Once it is that badly damaged, there is only one treatment. Take it out surgically. So surgically replace the aortic valve. That's the only available treatment. For many reasons, many people can't go for such open heart expensive surgeries in India and abroad. So we got interested into looking into what happens to those who doesn't go for surgery. And we found it's really interesting and fascinating. They just don't fall down and die. But if you see a long period of time, the graph is flat, they do well. I mean, they're not active like you and me, run around and all that. They're slow, but they pretty much do well. They don't die of an attack or whatever. They do well. But at some point of time, the curve changes where they tend to develop either pain or breathlessness or loss of consciousness. And once that happens, they quickly deteriorate and die. So we said, obviously, at that point, the disease has worsened. What is so funny about it? But when we repeated the echocardiogram, we found the disease remains exactly same. Not that at that point the disease worsened, disease remains same. Then why did they suddenly die? We didn't have an answer. So we thought we will look into more common diseases like what we call as angina. Angina is a disease that results from narrowing of heart arteries because of deposition of such fatty materials in the arterial wall. which slows down the blood flow. So the patient gets some kind of chest discomfort. Doctor, when I walk a kilometer, I feel some heaviness in my chest. I stop for a few seconds, it goes away and I am fine. That is how a patient tells us about angina. Now the problem is, despite the nuisance, angina patients do well for a long period of time. We know that they do well worldwide, they do well. Until and unless a day when the character of the pain tends to change. The patient either feels a pain which has come at a lesser exercise or at rest. And at that point, the change of nature of pain, somehow within the next 3 months or so, they tend to end up in a heart attack. So we thought the disease would have worsened. We did angiograms and found no, the block is there, but it still remains mild to medium degree. It has not worsened. Then why did the patient get a heart attack in the next couple of months' time? We did an unusual kind of scanning, which is called an optical coherence tomography. In this scan, we thread in a very thin tube which goes through the artery, enters the heart artery, and it's like getting inside the artery and crawling and looking around. Understand that this is a 3 millimeter diameter artery. And when we did that, we found that there are small areas of which are frayed and irregular. It's like, a good paved road has become irregular, potholes, or something like a carpet got frayed, a small area of fraying of the smooth carpet inside the arterial wall. So the point is, the moment a patient says there's a change of pain character, he develops a frayed carpet inside his artery, right? And we know that in the next couple of months he's going to have a heart attack. So simple information of pain is so very important. Look at something totally different. Painless kidney tumors. Something different. Many of the kidney tumors, initially, till they grow to a substantial size, they're painless. I might be harboring one, I don't even know. But fortunately today, for very many reasons, we get a routine scan done for the stomach. You go for an executive health checkup, your doctor might say, why don't you get a scan and done? And because we do such routine scans, many of these kidney tumors are picked up. And the moment they're picked up, we thank the doctor and say, oh almighty, it's good that my kidney tumor is diagnosed, surgeon operates and we are happy, right? Now in US, last year, they mapped out the incidence, the percentage or prevalence of CT scans done for routine checkups in their entire population, and they took out a group of between 65 and 85 years. Look at that color map. Those who are red, there the scan rate is 47%. Those states which are lightest have a scan rate of 30 to 37%. Huge, huh? Huge. So a lot of people of that age group get scanned for very many purposes, not to diagnose a kidney tumor, but because of this massive rate of routine scanning, kidney tumors are being picked up. And the rate of kidney tumor pickup has almost doubled in the last 40 years. Look at that arrow. The graph has gone up tremendously high, which is a good thing. But surprisingly, despite all this huge number of kidney tumors being removed out of the body, the death rate of kidney tumor has not changed. Why? People sat together. Is it because those painless kidney tumors are different from the ones that would become bigger and painful? We just don't know. We only know that once there's a pain, the whole natural history changes. In fact, one of our top medical journals wrote an editorial which says that use of advanced imaging test in the not so incidental tumors producing incidental harms kind of stuff. So nobody really knows why that happens. So finally, the concept is this. We know that there are diseases which we say early disease, mild disease, any disease, and that over time tends to progress onto an established disease. And finally it becomes an advanced disease, right? Any disease, no disease, mild disease, medium, severe disease. And we also know that, let's say pain, any symptom of pain, symptom is a complaint. No symptom, that becomes mild symptom and becomes severe symptom, right? Now intuitively we all tend to think that they are matching. Oh, mild symptom, mild disease, no symptom, very early disease, severe symptom, severe disease. No. That concept is wrong. That concept is absolutely wrong. The moment a person gets a mild pain, there's a change in underlying pathology. There's a change in his natural history of the disease. You've seen that aortic valve from flat to down, angina, any disease. And the moment he gets a new symptom of a pain, there's a change. There should be a change of the management strategy in the mind of the physician. And that is important. So, friends, that's why we say that, high-tech, cutting-edge technology has changed the face of medicine. Cutting-edge technology has changed the face of medicine today. So, I always say that scanners have changed our manners. Scanners have changed our manners. The moment a high-tech scan comes in, we can't resist. We look at that. And all our decisions today are based on angiograms, scans, high-tech tests and everything. Do that. Nobody says no, that's good. They are very sensitive. But do listen to the patient. Do not forget to listen to the patient for a couple of minutes' time, because that little information might tell you a lot about the change of natural history of the disease, which might be important in planning a change in your treatment formulation. And I believe God will not allow pain. God will not allow pain without allowing something new to be born. Thank you.